Good evening, Zimbabwe. You are listening to Studio 7 from the Voice of America on Monday, December 1st, 2014. And this is Live Talk. I'm Blessing Zulu.
And I'm Kip Stube.
And tonight on Live Talk, we are going to talk about the World AIDS Day.
To join the discussion, phone us directly at this number, 001-202-619-2077, and we'll call you back.
And as usual, Live Talk goes out to Zimbabwe on our 909 medium wave frequency and on the 4930, 5940 and 15455 kilohertz shortwave, Monday through Friday at 8:30 p.m.
And on the internet, you can find us at www.voazimbabwe.com, www.voashona.com, and www.voindevele.com.
We've had this kind of thing done in Rwanda, and last year it was in South Sudan, and this is the third time we're doing it outside the AU Commission, and we are doing it here at Victoria Falls.
Vanga vachikurudzira nyika dzese kuti dzikwanise idzo kuti dzibatsire vamwe vari munyika yadzo vari kurarama neutachiona hweHIV, uye vachidada nenyika ino yeZimbabwe kuti nepatasvika kunyange zvazvo tichiri nezvakawanda zvatinofanira kuita, asi vataridza kuti vari kufara nepatasvika pari zvino.
Okuqakatheke emhlanganweni lo yikuthi abantu abaphila legciwane benelisile ngokuthula ukuhambisa esingathi i-position paper ukuthi bona balemicabango bani batshele ukuthi kulungisweni.
Once again, thanks for joining us. And for those of you who are just joining us tonight on Live Talk, we are going to talk about the World AIDS Day.
Zimbabwe joined the world in commemorating the World AIDS Day, which started in 1988 to raise awareness about HIV and AIDS and to work to end the epidemic.
Health Minister Dr. David Parenyatwa delivered the keynote address in Victoria Falls at the commemoration, saying there is need for homegrown solutions to try and reduce donor dependency. An estimated 34 million people have HIV/AIDS worldwide.
What do you think about this issue? If you wish to join the discussion right now, phone us directly at this number, 001-202-619-2077, and we'll call you back. That number again is 001-202-619-2077. You can also send us a message on WhatsApp. Our number is 1-202-465-0318. Ye kungakunjalo mfowethu.
Honguka Gibbs nasi musi wa 1 zvita izwa rekuti pasi rose rinobata nairo mukucherechedza zuva rinenge rangarirwa kana kuti nezvechirwere cheHIV AIDS. Nhasi kuZimbabwe mhemberero idzi dzanga dziri kuVictoria Falls, kunova iko kwangwine gurukota rinoona nezveutano Dr. David Parenyatwa nevamwewo vari muchirongwa ichochi chekudzivirira kutapurirana kwechirwere cheHIV AIDS. Gibbs.
Yebo kambe Zulu ngandaba lingatshona njani lapha likhona khona ngapho ke ngemakhaya thina hayi siphilile sibili owamagama. Lamhla ke ingxoxo yethu sikhuluma ngelanga eliqhakathekileyo kakhulu ele World AIDS Day. Sizwile ke ukuthi eZimbabwe abantu bebethe gwaqa khona ngale ke Blessing eVictoria Falls lapho kade kulo mphathintambo wezempilakahle umnumzana David Parenyatwa, bese kubuya ke labanye abavela kunhlanganiso ye-African Union. Sizwile kakhulu ukuthi kukhulunywe okunengi, bekhuluma ngokuthi ke imali yafunakala ukuthi abantu ke behlaselane lo mkhuhlane lo. Sizwile njalo ukuthi bakhona abanye abaphila legciwane le-HIV kanye le-AIDS akade bekhona ngale emhlanganweni abacelwe ukuthi bakhulume bethula ke abakufunayo bona, besithi kumele benanzwe kakhulu ngoba isimo sabo singazani singeke sahamba kahle nxa ukuthi bengatholi okumele bakuthole. Sizwile njalo ke ukuthi ke eZimbabwe lilizwe Blessing engani lile uhlelo ole-AIDS levy okuthiwa ke luyasebenza kakhulu. Batshayela ihlombe sibili ngabantu abavela ku-AU, lapho sikhuluma ngabantu abavela eSwaziland, Tanzania, Zambia lamanye amazwe. Besithi i-AIDS levy leyi ikhanya siyathola about $150 million. So kwadlula ke i7 years kusayenziwa khonokho. so bati imali leyi iyanceda kakhulu.
honguka sekutaura kuri kuita Gibbs chirongwa che-AIDS levy chekuti vari kushanda vanenge vachibatirwa mari chinonzi chiri kuyemurwa zvakanyanya nenyika dzakawanda nekuti vazhinji vanovimba nemari dzinenge dzichibva kune vekunze kana kuti hatingati madhona, asi Zimbabwe iri kuonekwa kuti pachirongwa ichochichi iri kukwanisa kuti hurumende yeZimbabwe nevanhu vemuZimbabwe vazvitsvagire mari yavo vega vasinganyanyoende kunze uku kuti vaende kunotsvaga mari dzekutenga mishonga yema-ARV nezvimwe zvinodiwa pakurwisana nechirwere ichochi chemukondombera. Saka nyika dzakawanda dziri kuti dziri kutodzidza kubva kuZimbabwe pamusoro penyaya yekurwisa denda iri. Gibbs, any guest at the moment?
We understand that we have got Professor L.P. Sibanda, who is a health expert. Is working with the University of Zimbabwe, a National University of Science and Technology. Professor Sibanda, good evening and welcome to the program.
Thank you. Good evening to you.
Thank you so much.
Professor Sibanda, of course, the world today is commemorating the World AIDS Day. Would you say we have made significant progress in fighting this epidemic?
As one of those people who started his career with the start of AIDS, the emergence of AIDS in 1984 was when I started my medical career. And now, 2014, I can certainly say a lot of progress has been made in the last 30 years. We are now able to treat this condition and to manage it, and we are not at the stage where we were when the people were just dying from the disease. So in the last 30 years, we've made a lot of progress, internationally and nationally.
What do you think were the major challenges that you faced in tackling the disease?
There are different phases. The very first phase, our biggest challenge was stigma. People just did not want to be known to be infected. That phase was also associated with fear. People were afraid. And thirdly, that first phase, we were faced with a situation where doctors did not know what to do with the disease. We didn't have medicines, and we just were as blank as the patient. That was the first phase and its challenges. Then in the 90s, our biggest challenge was our sheer volumes of people who were infected. And the disparity between the volumes of people infected and the availability of drugs to manage them. Not only the availability of drugs, but also the availability of expertise from the medical profession to handle this disease, which was new to most of us. I think the final phase that we are talking about is really a phase of success, where most of our healthcare workers know how to deal with the disease. The problem of stigma has almost been overcome. Most people accept the condition. The drugs are more readily available and they are affordable. And the numbers of people that are infected are decreasing. So that's the final phase, which brings us to 2014.
Thank you so much, Professor Sibanda. Please do stay on the line. Professor Sibanda, vari kutiwo zvinhu zvinenge zviri kufamba muchirongwa chekurwisa chirwere ichochi che-HIV AIDS, vachitaura kuti pachakatanga vanhu vaitya kuti munhu atonzi ane chirwere ichocho vanhu vanga vasingadi kuti zvizivikanwe. Mishonga yanga ichiri kunetsa kuti vanhu vaiwane, asi iko zvino vari kuona kuti zvinhu zvinenge zvanani, vanhu vakunzwisisa uye mishongawo yekuti vanhu vange vachirapwa inenge iripo. I think we are being joined by our second guest, Gibbs, that is Mrs. Martha Tolana of the Zimbabwe Network of Women Living Positively with HIV AIDS. Mrs. Tolana, good evening.
Good evening, how are you?
I'm doing great. My Tolana, ngati tariseiwo.
I just want to correct, the organization is International Community of Women Living with HIV, ICW.
International Community?
Of Women Living with HIV.
Of Women Living with HIV.
Yes, the acronym is ICW.
ICW.
Yes.
Tangata kupai imwe sangano.
Yes. Yes.
Rega nditi mai Tolana, tichitarisa nyaya yekurwisa chirwere ichochi chemukondombera, mukati Zimbabwe yasvika papi tichitarisawo zvamuri kuona zviri kuitika nemasangano amunoshanda nawo?
Pari zvino kunewo progress nezvikumwe kwekuti tiri kudzoka mumashure. Tinenge tiri mumashure pane zvino. Ndofunga ndingangoti handisi kuona tati tanyatsoti taapo chaipo nekuti mukondombera HIV inenge inoramba ichichinja nekuti tiri kudzidza zvakawanda nguva nenguva. Saka zviri kuuya zviri very fast. Saka ndofunga kuti kuti tikwanise kufamba neinformation yatinenge taakuziva tinenge tinosarira mumashure mbichana. Asi pari zvino ndinobva kuti taakuziva zvakawanda pamusoro pe-HIV. Kana taakuziva zvakawanda kuti zvipatara zvizhinji nemakiriniki mazhinji akukwanisa ari kukwanisa kubatsira vanhu vanenge vaine utachiwana, vari kurarama neutachiwana hwe-HIV. Asi zvetiri kuona kuti kuchine kumwe kunoti netsei kwekuti stigma rusarura kusemwa kunenge kuchiripo muvanhu. Ndikanyanyotarisa pavana, ndofunga dambudziko pavana nderekuti vana havasi kuudzwa. Vana vanenge vazvarwa vari HIV positive, dzimwe nguva havasi kutaurirwa kana kuti vanowana utachiwana vachiri vadiki. Asi ndofunga pane mubereki zvinenge zviri kuomera vabereki kuti vataurire mwana kuti mwanangu une chirwere che-HIV. Uyezve vamwe vanenge vachirarama neutachiwana vanenge vanoti netsekei futi kuti vataurire vana kuti inini mubereki wako ndine HIV. Asi kunewo vamwe asi tiri kuona kuti mbijana tiri kudini, tiri kuwedzera. Asi pavana apa ndofunga pamwe pacho pari kuitwa nekuti kuchikoro vamwe vakaziva vanozvibata sei, nekuti ndofunga mamwe mashoko ekubatsira paHIV achiri mumashure haasiri kuenderana nekuti izvozvi mumwe munhu anenge asina kuchibatira pabonde asi kuti akazvarwa ainacho. Iye munhu aane 20 years akutsvagawo wanano 20-25 years ane utachiwana akazvarwa ainawo ari kutsvagawo wanano. Saka papo panoti netsei nekuti panenge mwana anenge asina kupihwa achikura kuti meseji yaari kunzwa ndeyekuti ane utachiwana akahuwanira pabonde. Saka ndofunga ndo mamwe matambudziko atinawo kuti patinofanirwa kushanda chaizvo kuti pavana apa nemuzvikoro kuti vana vazive kuti hakusiri kungoti chete. Ndaiona kuti madhirama dzimwe nguva anenge achiitwa muchikoro kuti munhu ari kuenda mumabhawa achirarana neupi ndiye anowana utachiwana. Asi ndofunga meseji yedu inofanirwa kuti ichinje ichienderana nezviripo mazuva ano.
Aiwa, masimudza mashoko akakosha zvikuru. What Maitwalana is saying is that of course progress has been made, but she's still very, very worried about the issue of stigma, especially in children. You know, there's this mother-to-child transmission. She's saying that sometimes mothers are finding it very difficult to tell their children that they are HIV positive until they struggle when they now want to get married, and even for them to understand it, it's difficult. People think they were promiscuous and some of those issues. Maybe it's a question that we need to pose to Professor Sibanda Gibbs.
Yeah, kunjalo ke baba Sibanda uyazwela lapha umama uyakhuluma. Utokuhluphayo kakhulu ukuthi nxa umntwana sekhula khulile wazibona ukuthi ulomkhuhlane lo awuthola kwampane ezalwa ngani kuyahlupha. Phoke istigma esinje setshenzwa njani?
Istigma lesi siyahlupha njengoba umama lo ekhulumile. Sihlupha indawo mbili. Sihlupha umzali, sihlupha umntwana, sihlupha utitsha. bonke abantu labo abale involvement lo mntwana kuyabakhathaza ukuthi bachone njengoba kukhulunywa ukuthi kungabe istigma lesana singapheli umuntu ongumzali uyesaba ukutshela umntwana ngoba uzacabanga umntwana uzambona amkhangele njani uzamkhangela njani njengoba kuthiwa umkhuhlane lo ngabantu abangaziphathanga kuhle so kufanele kube lesifundiso esihle kakhulu khonapho ukuthi umkhuhlane ngumkhuhlane uyafanana le-cancer lani akula mkhuhlane umuntu ahamba waya ukhe esihlahleni ukuthi sengifuna umkhuhlane lo ngufake esikhwameni wenzakala uthi singakhuluma ngakho konokho sizama ukuxwayisa abantu kuhle ingxenye kungaba ngcono khonapho ebantwaneni kulapho kusasenzima khona okunye ongakhulunywa ngumama ukuthi i-problem esibona kulezi nsuku ivame ebantwaneni abaleminyaka 16 to 25 ikakhulu abantwana abangomama amankazana 16 to 25 kulapho esesibona umkhuhlane lo ungakapheli kuhle khona abadala labana sekungcono abancane labasanda ukuzala sekungcono ukuthi umuntu ngathi esinxa ezithwele usehlehlolo ukuthi umkhuhlane ngabe ukhona yini ahlelatshwe esazithwele ukuthi ngesikhathi ekhululeka umntwana kukalutshwana ukuthi akhululeke kathesi ngalonyaka ukuthi umntwana akhululeke enomkhuhlane ngaphandle kwalabo abangazange bezixetsha lokuyabonana lokuyabhalisa ukuyabhalisa lokukhululekela ezibhedlela abakhululekela ezibhedlela iningi labo abazali babo basebeselatshwa ukuthi umntwana ezalwa laphana ahlazalwe engelamkhuhlane so kusasele bridge ekhona khona kuma late teenagers 16 to 25 ngokuthi labo ngesikhathi bezalwa 16 years ago sasingaqalisa ukwelapha abazali bonke so bakhuthwa isikhathi that's number 1 yibo abakhulunywa ngosisi la number 2 umkhuhlane iyavama kuyona ne-age group ngenxa yokuthi kwesaba lokhane sasilakho kuma 1990s late 80s abazange bekubone babe ngabantwana so sekuyinganekwane zabazali ukuthi umkhuhlane wakwahlupha so abantwana abangama-teenagers nxa sebenza ama-experimentation abo kusuka kudlulela phambili bekusuke bebamba umkhuhlane besasebancane.
So Professor Sibanda is actually acknowledging that there is a problem like what Mrs. Tolana is saying, that, you know, this age group between 15 and 25 is the same age group that didn't get a lot of counseling, maybe during the times when the disease was coming into, you know, into light. So he says at the end of the day, it's problematic, but people should actually come out in the open and say, okay, this disease is just like any other disease, like cancer, you know, or any other. So he says there's really need to tackle that kind of problem within the age groups 15 to 25.
But Professor Sibanda, if I may just ask one question quickly, at what age should a parent sit down with a child? You know, there's this mother-to-child transmission. At what age should a parent sit down with a child and talk about the disease?
With all due respect, parents are parents, and in our culture, the gap between parent and child is wide. We used to have a time when the aunties were coming in, and they were nearer to the child than a parent is. That gap psychologically is still there. So I think what I personally suggest, I don't know what the guidelines say, is that it's better for the parents to seek help, professional help, as soon as they know, and then the professionals can then lead them and lead them and see at what point both parties are ready, and also coach them how best to advise the child, because the way you communicate this disease is a very emotional way. Parents will be emotional, children will be emotional. So you need somebody like a counselor who will bridge the two. And my suggestion, as soon as the parent knows, let them seek help. There's no date or time when you can tell a child. It's a process, and it can take a year or two before both parties are ready. But what needs to be acknowledged is that we should not delay the treatment of a child in order to wait until the child knows about the situation. That there should be a balance there. Health first, safety first, but the process should be held very, very delicately because its implications are long-standing.
Thank you, Professor. Mrs. Tolana, let's talk about the availability of drugs. Are they readily available? Because we have had reports of some people complaining that they are now being sold on the black market.
Yeah, I think this we've had this ever since the start of provision of ARVs in Zimbabwe. It has been, I think it has been a common refrain that sometimes you get to the hospital, there are no drugs, but you are accosted by someone as soon as you leave. As soon as you leave and said, "Oh, which drugs did you want?" I do have them, and for a cost, of course. And because people now know and they are desperate, they'll go for that, but not knowing that they are putting themselves in danger. But I think, as far as I know, I think there's been great strides in trying to combat the theft of drugs. Although I think in any situation, there's a lot of times the new tricks will be engaged. I've also read the recent report, and this is something that I wouldn't say is not happening, because sometimes we do hear people, we do say we have enough stock from the Ministry of Health and National AIDS Council. There are enough stocks, but at times you hear people who say they couldn't get the drugs. So yeah. So in many ways it's very difficult. But I think we need to ramp up our treatment literacy and advocacy for the communities, so that really communities, if people do not buy from the black market, it means no one will be, they won't be, the people who are selling won't be able to sell them to anyone. Or even, I think the problem that we have now is that with a lot of things, in commodities in Zimbabwe, people think we have now got used to getting things. If you can't find something that you really need and you get it on the black market, you just buy it. Look what happened with basics like sugar, food, basic food. If there's no cooking oil in the supermarket tomorrow and someone is selling them, the answer will definitely go and buy it. So I think that's the same situation, because this is a matter of life and death for people who are living with HIV. Yeah.
Thank you, Mrs. Tolana. For those of you who are just joining us.
I also wanted to come in on the when to disclose. I think that when the fact that we are still asking that question, to me, that's the proof of the stigma that we have in the society. When do I disclose to my child? For me, I was told I was burdening my child by telling her my condition. But, today she's 11, and I'm happy that I did what I did when I did. Before she could even start talking, she would see that I'm taking these medicines, and I talk about them. But it meant along these years, I now go at a pace without having to worry, how much do I tell her? She just knows that she's my treatment supporter now. So for me, I think we need to change the way I wouldn't want anyone else, telling my child. I think it becomes different now when you get infected. Maybe children are a bit older, and you have to break it to a child who is, older. So we now understand issues, and there's all this stigma around it. Then it becomes difficult. But also for me, when I was disclosing, I also wanted to be prepared when my child tested. If she was going to be positive, I wanted to be able to be ready and able and comfortable enough to talk to her. And at the end of the day, we need to acknowledge that it's a personal decision. It's what works best for it. It's not, I don't think we can have a formula. But I think we just need to look at our family situation and look at how best can we actually make sure that we are living a balanced life as a family. Because for us to be able to function out there in the society, there needs to be balance in the family.
Thank you so much, Gibbs.
I think we're joined by a third guest, and that is Mr. Sipho Mahlangu, who is an HIV/AIDS activist and is based in Matabele North Province. Mr. Mahlangu, good evening and welcome to the program.
Thank you very much, although I'll be with you for a short time.
Hayi kulungile ke ususebhasini konapho.
Yes.
Ya okay ngamafitshane nje akusitshela ukuthi elihlangana lakho ngamalanga ekuyini ongani kunzima.
Ama-challenges akhangelane balikhuluma ngabantwana la. Ama-issues e-stigma. Kule issue yokuthi umntwana yena ngokwakhe abe lokuzwisisa ukuthi i-HIV yini kuthatha isikhathi. And then kule issue yokuthi umntwana uphenduka abe yi-object. Kuyi-object of pity yini kumbe kuyi-scapegoat abadala bathethisana ngayo. All those issues they come into play.
Kodwa ke lina ngwenu imali lithola ngaphi nxa kuyikuthi umembi ufuna imali yokuthi uwelatshwe kumbe into ezinjalo?
Besilapho silodubo lokurelaya nge-social assistance esiyithola kuhulumende, but ama-procedures akhona sengathi ahlupha. Ungananzelela ukuthi ama-coffers vele e-social health ahlale engelalutho. So sesirelaya wona ama-AIDS service organization abakhona abalozwelo alama-program abantwana ama-ofisi yiwo asincedisayo kakhulu ekubhadaleni lama-skills abantwana lokuthi take futhi ama-needs abantwana abangamankazana abancane la.
Ye nxa sisikhangela ama-ARV ke liwathola ngaphi ahluphi yini?
Ama-ARVs alokuhlupha nxa especially sebantwaneni abancane ama-suspension kulesikhathi sokuthi aswelakala bese isikhathi sibuyela kwisystem yona leyani yokucrasha amaphilisi. Yikho kuba buhlungu kakhulu khonokho ngoba sabe sidinga izindlela zokuthi umntwana lwana athi to-take ama-drugs lawana engamkhathazi ngokuba solid. Sabe sisebenzisa izindlela eziningi, ezinye ngeziyani orthodox ezingalunganga kuhlanganisa lokunye changing ama-chemical component e-drug.
Hayi siyakuzwa kakhulu ukuthi uyatravela nje sizakuxolela okwalamhlanje.
Ngiyabonga. Hayi ngibhekene lesiphiso esibili sokuncedisana la.
Yeah, hayi sibokile kakhulu ke Mahlangu ungadinwa kusasa.
Thank you very much.
Yeah, so he's saying that the problem is that most people don't access ARVs, and at times some of the ARVs that are targeted for kids, they are in a solid form, so they have to crush them, mix them with something, but while they are doing that, they almost lose a certain kind of chemical composition, which is very dangerous according to him. And he says those kids that have got HIV, in most cases the school, they become sort of like objects of pity, like when some people know that, oh, this kid is HIV positive, they start doubting her and those kind of things. So she says that's a problem. Even at home, he says when parents are fighting, they'll start talking about the kid as well, like using her or him as a scapegoat for certain things.
I think we'll talk to the professor about that later on. But of course, for those of you who are just joining us tonight on Studio 7 Live Talk, we are talking about the World AIDS Day. Just some facts about the disease. Of course, the World AIDS Day started in 1988 to raise awareness about HIV and AIDS and work to end the epidemic. HIV, or human immunodeficiency virus, is a virus that attacks the body's immune system. HIV can progress into AIDS, and the final state of the infection when the body is unable to fight a disease or infection. And of course, an estimated 34 million people have HIV. That is HIV/AIDS worldwide. And of course, sub-Saharan Africa has the most people living with HIV in the world, and 70% of all new HIV infections occur there. That is in sub-Saharan Africa. That is in Africa. And in 2013, there were an estimated 24.7 million cases in the region, that is in Africa. This is according to the World Health Organization. And of course, there is no cure for HIV, but antiretroviral drugs, or ART, have helped people live longer with the virus. In 2013, 12.9 million people received the drug therapy. This is also according to the World Health Organization. And from 2005 to 2013, AIDS-related deaths globally have decreased by almost 40% across age groups. So those are some of the facts, Gibbs. We'll be back. Professor Sibanda, stay on the line, and also Mrs. Tolana. Our radio listeners, go to www.voazimbabwe.com. We are streaming live. This is Blessing Zulu.
And I'm Gibbs Dube. Stay tuned.
For those of you who are just joining us, good evening, and this is Studio 7 Live Talk. And tonight on Live Talk, we are talking about the World AIDS Day. Gibbs.
If you wish to join the show right now, phone us directly at this number 001-202-619-2077. Ngabafuna ukuthi nje bangene kuhlelo khona manje. Nasi inombolo lisifonele kanye. Cellphone khona ngapho ngemakhaya. Ye, bambani number xa ukuthi ungela ballpoint ilahle. Ubhale phansi 001-202-619-2077. Ye, mphinde njalo 001-202-619-2077. Yes, I
think we only have a few minutes with Mrs. Tolana. She has another engagement. Mrs. Tolana?
Yes, I'm on.
Yes, maybe just your last word about the way forward, what can be done to make sure that the progress that has been made will not be reversed.
I think there's need to link more with a lot of the research that is happening with very good results. But then it comes to the implementation now, which is not keeping up. Because and also having the information that has come out of the research, of the clinical research, going to the communities, to the society, because I think this will help. And I'm also thinking around the children's issue is something that concerns me a lot. And I hear what Mr. Mashangu said about the medicines that we have to, if you crush the pills, then maybe it's not the dose and there needs to be formulations. Yeah, that is true, and we would. I think then that's where it would need to look to have more from clinical research to say what is the best formulation that can be taken by children, because I would want anyone to take that crushed tablet. Yeah, and it was test what it's like. And to think if a child, if one cannot take it as an adult, will a child take it? And even the pediatric formulations, how palatable are they? Maybe adults to taste them, to just put a drop on their tongue, just to feel how they taste.
Yeah.
And then they would understand to what the difficult, even though that's the formulation for children. But is it something that is easy for the children to take?
Mrs. Tolana, thank you so much for joining us tonight. I know it was such a short notice, but thank you so much for your contribution and understanding.
Thank you very much.
Thank you.
Now let's turn to you, Professor Sibanda. You know, this crushing of these drugs, is it workable?
I think it's not an ideal situation to crush drugs. But in the absence of alternatives, it's the only way to go. But generally speaking, the pediatric formulations have increased in number and in variety. So the choices are increasing every day. Although, of course, due to issues of drug supply and supply chain management, there may be occasions where a child has to have drugs crushed. Because we advocate that people should never miss any dose. So if you have to breach the dose by crushing the medicine, it's sort of a half a loaf being better than nothing. It's not the ideal situation.
And there is also talk about the mother-to-child transmission, and the last figures that came out from the Ministry of Health, there was a significant progress that was being made. Of course, the target being 0% transmission from mother to child. What more can be done, Professor Sibanda, to ensure that the 0% transmission target is reached?
There are several components to this. The first is the preparedness that our healthcare providers have, where they are trying to train and teach mothers how to come up early and to be seen and to be diagnosed as early as possible. But the healthcare providers cannot work alone. They need the resources which will enable them to have all these medicines in place in time. And then there's a third component which is not spoken about frequently, is the issue of trying to confirm that a child is or is not infected, so that we do not burden children with medicines which they may not need at a given point. And these tests to confirm these things are expensive and are only found in central facilities like the reference laboratories and the central hospitals. And it takes a bit of time before the child can be known to be HIV negative. And that has implications as well in terms of whether we're going to breastfeed this child or whether we're not going to breastfeed, depending on the circumstances. Although the general guidelines are that all children should be breastfed, some mothers may have some other options of their own.
Thank you, Professor Sibanda. Gibbs.
Right now, I think we are joined by another guest, Madeline Dube of the National AIDS Council. She is in Victoria Falls right now. She was attending this AIDS day, which was held at the resort town. Ms. Dube, good evening and welcome to the program.
Good evening, Mr. Dube. How are you?
Very fine. How is Victoria Falls?
It's okay. Not very hot.
After the event that you held today, I guess you went bungee jumping. What is it called?
Bungee jump.
Bungee something, right?
Why?
After achieving what you may have achieved, I think you can pose a question to her.
Yes, I was suggesting you start a law firm, Dube, like our practitioners. Now, Mrs. Dube, tell us about today's program. How did it go?
We heard from our participants, those who were part of the meeting, that it went on very well. As organizers, you'll be really like tense as to whether things will fall in place. But we're happy to say today we were co-hosting our World AIDS Day with Africa Union Commission, and we had the Commissioner for Social Affairs, Dr. Mustafa Siddiqui Kaloko. And our guest of honor was Dr. Parinyatwa, the Minister of Health and Child Care. We were so happy that we had our partners, both accredited to AU, the UNDPs, your UNAIDS, your Global Fund from Geneva. We also had a number of those internationals. We were quite happy that they could grace the occasion, give solidarity messages, and also commit their support to what Zimbabwe is doing.
What do you think were the major issues that were discussed at the meeting or event?
Starting from yesterday, we had a high-level meeting chaired by the Minister of Health and Child Care, which was focusing on domestic financing. The issues were that as Africa, we are endowed with a lot of resources, a lot of natural resources, but we're failing to turn around our health delivery systems in the various African countries, and we are relying more on donor funding than we can do for ourselves. So it's high time that countries should look at the possibility of utilizing the resources which they have, that they should come up with initiatives which then help them to allocate resources either from government or either from the natural resources which are available to service the health delivery system, and more so in the fight of HIV and AIDS.
And now I think the Ambassador Kane Matema, coming to you, Professor Sibanda. Ambassador Kane Matema was, who is the Matabele North Minister of State, was saying that Matabele North is one of the 3 provinces with the highest number of people living with HIV.
Sure.
Professor Sibanda, what can be done in areas such as Matabele North to at least ensure that the infections are reduced?
Well, it's very difficult to know what can be done in any given province. Matebele North is a rather large province, which, to my recollection, does not have many major hospitals. I think the few I can recall is St. Luke's Hospital in Lupane, and from there you go to Wange. And then in between those 2 cities, towns, there are no major hospitals. And therefore the access to health care appears to be limited by access to the availability of healthcare facilities.
Very true.
In a given area. So what you then need is a robust outreach system, but that in turn requires resources, which will enable a robust outreach, because it requires vehicles, people, and so on, who will do the outreach programs within the province. It's the vastness of the province and the absence of healthcare facilities which may be contributing to this. I'm not privy to the reasons why it's high, but that's what comes to me. You have St. Luke's, you have Cholocho, you have Wange, and that's about all, really. Perhaps Nkai as well. But that's all.
Thank you, Professor. Muzvinafundo Sibanda, mashona unonzi muzvinafundo.
esindebeleni kuthiwa ngusikhwica mfundo. Xa ushaya isikolo silokuzwayo wena wasijambi njani? Wasizama lawo beni. Lawo uprofessor in your own right.
Muzvinafundo Sibanda vari kuti iwo kunzvimbo dzakaita seMatabeleland North kune inzvimbo yakakura, kune vanhu vakawanda. Chimwe chinogona kunge chiri kunetsa inyaya yekuti zvipatara zviriko zvishoma, nekudaro panodiwa mari yekuti pawanikwe vanhu vanenge vachipinda mumatunhu akaita sana Matabeleland North vachidzidzisawo vanhu nezvechirwere ichochichi che-HIV AIDS gips.
Wotisizwe kuwe Madube po kungabanjwa njani khona ukuthi njengoba kuthiwa isabelo seMatabeleland North yiso singane silenkinga. Po kumele kwenziweni khona?
Iqiniso inkinga ingabi khona, ukufundiswa kwabantu kuqakathekile, kodwa lakho bekumeleke sikhangele senze singathi ngesingisi yi-research yokuthi sihlole sibone ukuthi kuyini okubangela ukuthi Mat North ibulawayo kanye le-Mat South kube zindawo ezilegciwane eliningi kumbe abantu abaphila ngegciwane eliningi. Okunye kwangikhona kungaba kubangelwa yindawo yokuthi iVictoria Falls indawo evakatshelwayo, yi-resort center. Ngakho abantu ababuyayo abanye kabahambela ukuzobona ama-falls kuphela, bahambela okunye. Khona lokho kuyasiphazamisa. Bengike ngakhathazeka ngisiza eminye impiko yokuthi kukhona obaba kumbe omama abavela phesheya kwamazwe okutshengisela ukuthi babuya bezodinga izithandani eVictoria Falls. Bakwenze njalo ukuthi umnyaka munye ngamunye umuntu uyabe evakatshelwa. Umuntu lo oyabe esekhombileke engapha eVictoria Falls, ngabe indoda ngabe ngumfazi, abesekela-ke la ukuthi amelele lowana ukuthi azaphenduka, aphinde abe lomunye njalo. Ngibana bevakatsha ngesikhathi esitshiyeneyo. Yathola ukuthi ungezwa ukuthi umuntu ulabantu uthandana labantu abahlanu abangaphandle kwelizwe, abambhadalelayo indlu, abambhadalelayo ukudla. Kusitsho-ke ukuthi ukulamba kwesinye isikhathi kokwenza ukuthi abantu badingeke indlela zokuphila ezinye zangikhona ezibafaka phakathi kwengozi yokubanjwa ligciwane.
Yeah, kukhanya ngazani lapha kuyahlupha sibili. What she's saying is that there's need for Zimbabwe to conduct research to find out exactly why this is the case, in terms of having more HIV figures in Mount North. So she says one reason may be that Victoria Falls is a resort center, where we've got these visitors from different countries. Some go there for watching the falls, but others are always looking for love. So she says at the end of the day, a person can have a lover, that is in Vic Falls, who he or she will visit after a certain given time. And then when that person doesn't visit at that particular time when she needs a man or a woman, then she may have many lovers, So at the end of the day, that kind of, the thing spirals out of control. Maybe having even five lovers from abroad. So this becomes a problem, according to her. But she says definitely there's need to conduct some research.
Indeed. Research. That's the key word. Professor Sibanda, coming back to you, we've seen that funding for HIV/AIDS has been on the decline. There was a world economic crisis, of course, in the past 2-3 years. But still, not many countries are willing to commit money when it comes to fighting HIV/AIDS. And we are seeing that in sub-Saharan Africa, this epidemic is still problematic. What can be done?
I've been listening to what has been discussed earlier in the day. I think in that regard, we can say Zimbabwe is a proud leader in trying to find domestic resources. Zimbabwe has initiated what is called an AIDS levy, which has been running now, I think, for the past more than half a decade. And the concept there is to try to make sure that there is a tapping of domestic resources, which are thereafter channeled for the treatment diagnostics of people living with HIV and AIDS. The unfortunate challenge is that there has been an economic meltdown, which means that the resources that can be tapped from the employed are decreasing. But the overall concept has been an excellent one, and as one of the very early speakers said, it is being adopted and replicated, certainly across the SADC region, but hopefully more widely around the world. That's one of the things that nationally the government of Zimbabwe has initiated, a very, very promising initiative. What are the other alternatives? The other alternatives are, in my opinion, are that beyond looking at National AIDS Council and the resources that they're getting through taxation, essentially, perhaps the corporates, if they are there, wherever they are, could create a fund that looks after the communities that they serve, their employees and their families. That would reduce the burden of the National AIDS Council and allow the National AIDS Council to focus on those who are unemployed and who are, like you say, in provinces with a high burden, like the province we have just been discussing. So they need a refocusing of internal resources at a national level, as Zimbabwe has done, at a corporate level, as it has been done. But I think we should be able to cascade to perhaps village and community level, depending on the means and the resources of that community. And that's something that perhaps one should try to engage traditional leaders to see if there's a role that they can play within their own spheres of influence to alleviate this challenge, and certainly to deal with the issues of stigma and issues of access to medication, and also opening up facilities where children, adults, and expecting mothers can have advice and treatment.
Thank you so much, Professor Gibbs.
Yeah, Miss Dube, or let me say Matube, looking at some of the ways of trying to keep HIV/AIDS, we see that there is a medical male circumcision program that was actually, founded, or let me say that was started in 2009. Up to now, we are told that is still going on. So what is going on right now? Is it contributing towards the reduction of the number of people that are actually, getting this kind of disease?
Yes, it does. But, with male circumcision, for it to work, you need numbers. You need to circumcise a lot of men to avert one infection. I was going to go back to the issue about Zimbabwe being the pathfinder in AIDS levy in domestic financing. To say as National AIDS Council, we realized that the new funding model by the Global Fund really made Zimbabwe receive a lot of funding as compared to whatever we've received before. I know we have received, the highest was around 650, but this time around we've even received 551. Why? Because of the AIDS levy. Now, partners are saying, what is your own contribution as a nation? And as Zimbabwe, we've proved that it is possible for us as a country to raise our own funding and show our commitment. However, we have even gone further to look at other ways of how we can increase the number of people who can access treatment. So this is something which we have done in partnership with the medical aid societies. We're having challenges because the medical limits for individuals was maybe too small, or not even too small, but the price was causing people not to really benefit from that exercise. So we've been able to negotiate that we buy the medicines for the retail pharmacies for the various medical aids, so that people then access treatment at a cheaper rate. By so doing, the person needs to go to their doctor, get a prescription, go to the private pharmacy, and at the end of the day, they have their own medication. Unlike at the present moment, whereby someone can even get a prescription, but they can't afford, they couldn't afford the prices at the pharmacies. They could then go to the public institution, crowding those who can't afford treatment. Now we've seen that we have numbers who are dropping from the public sector, giving way for those who can access. The third thing is, as we realize the regimens are changing, maybe after 3 years. So we feel that we should capacitate, we should work with our local manufacturers so that we can see how best we can support them. At the end of the day, as National AIDS Council, we should not continue to buy from outside Zimbabwe. We should be able to buy from our local manufacturers so that we create employment for our people. And these are the same people who contribute to the AIDS levy. This was the same thing being raised by the meeting yesterday to say, how best can we assist our pharmaceuticals? Maybe we need to build a central or a common pharmaceutical company so that Africa can benefit.
Thank you so much, Mrs. Dube. Do stay on the line. For those of you who are just joining us tonight on Studio 7 Live Talk, we are talking about the World AIDS Day. And of course, we have some people who have sent us messages on WhatsApp. Gibbs. First, we have Carrington, who says Zimbabwe has taken a major step in educating people about HIV and AIDS as compared to some African countries. Gibson says we also need early teaching to the youths about the deadly disease, mostly girls. I don't know why he's saying mostly girls. And then Matthew says more needs to be done when it comes to behavioral change. Ed Moore says there are a number of strides that have been made and achievements in the reduction of this pandemic, particularly in Zimbabwe, though some reports of new infections are worrying. Those are some of the messages that we have on WhatsApp. Gibbs. Anything on Facebook?
Yeah, on Facebook. Ungazani ke incingo zethu asihambe kuhle. Ungani nizama ukuchacha lapha kwachaya kwayali. So kumbe ngaya Professor nje umbuze ngesintu. Ngithi ke Professor, nxa ukhangela ke lathi siqalisa khona ulwisana lo mkhuhlane lowo. Lalikhuluma ngalokho ukuthi umuntu kumele atshintshe izenzo zakhe. Kambe izenzo lezo sezaguquka yini ikakhulu eZimbabwe?
Lokho kwande ukumeasure ukwazi ukuthi ziguquke kanjani kunzima ngoba kasiyonto ngathi ukuthi 1 to 5. But abachoyo ama social scientists athi kulomahluko omkhulu namhla kulalokho besilakho 20 years ago, 30 years ago, and even 10 years ago. Umahluko wakhona ukuthi abantu sebekwazi ukuthi umkhuhlane uthathelwana njani. Ukusetshenziswa kwama-preservatives, ama-condoms is very high eZimbabwe. And ukuba high kwakhona kungabe kuyisitshengiselo sokuthi abantu sebatshintsha indlela abaziphatha ngayo. Ama-rates, ama-infections athathelwana, ama-STIs, sexual transmitted infections, they've gone down. Lokho yikho sibona ngani i-indirect suggestion yokuthi there's been sekube ne-change ye-behavior yabantu. But directly it's difficult ukwazi ukuthi i-behavior emfanele itshintshe yiphi, isitshintshe yafika nga. Esingakubona ukukhangelela eceleni ukuthi sikhangelela ngaphandle ukuthi hayi lokhu ngabe kuyisibonakaliso sokuthi sekwatshintsha.
So Professor Span was talking about behavioral change. He says maybe there's been some kind of behavioral change. If you look at the number of condoms that are being used in Zimbabwe right now, and he says, well, the number is high. And even when you look at the STI infection rate, is actually low. So he says those could be indicators that compared to, the previous years, maybe the infection rate is going down.
Mrs. Dube, there were problems, right, with the uptake of the female condom. Has there been an improvement?
Actually, Zimbabwe is one of the countries which has got a high number of condoms which are being accessed by women. But if you compare it with the male condoms, yes, you could say it's lower. But we are doing well in that area, and we continue to educate women and men as well on how to use the female condom consistently and correctly. One of the challenges was that people had complaints about the first female condom, but I think now people are changing because there's been a development, an improvement on the first female condom. And now I think the one which is on the market now is user-friendly to most men and to most women. If people are well educated on how you can use the female condom, you'll find that most people then quickly switch off to use the female condom because it's user-friendly as compared to the male condom, where you have to wait until the man is ready for him to put it on. With the female condom, the man, guided by the woman, can actually utilize that condom without much interference in the relationship, if I may say.
Thank you so much, Mrs. Dube Gibbs.
So, Professor Spanda, what do you think about that kind of organ that is being used?
I think there's an issue here of choice for all parties. And it is very interesting and encouraging that there has been a new development in the female condom, and it's more user-friendly now. And we do understand that the uptake has increased. And I think that is also one of the indicators that there has been sort of a behavior change, because we were not talking about female condoms just 10 years ago. They were not there. But we are now saying that they are used and used widely. And as the previous speaker says, more widely than in other countries. And
bless you.
If that is the case, then certainly there has been a behavior change.
And your last word, Mrs. Dube, do you have programs in place to make sure that what you discussed today will be carried through so that it won't just become a talking workshop?
True. It was actually one of the recommendations that we should sit down and come up with a communique to that effect and recommendations. We should be followed through by ministers of health, followed through even to the president's level through the organs of the African Union. So we do hope that we will see the desire for the meeting yesterday was that then Zimbabwe takes the lead in doing HIV and AIDS activities.
Mrs. Dube, thank you so much. Unfortunately, time is not our best ally. We want to thank our guests this evening. That is Professor Elopi Spanda, a health expert, and also we had Martha Tolana, International Network of Women Living Positively with HIV, Madeline Dube of the National AIDS Council, and also Sipo Matlango, HIV AIDS activist. Signing off, this is yours truly, Blessing Zulu.
And I'm Kips Dube. Good night.